It is now my pleasure to introduce Dr. Romilla Batra. She received her MD and residency training at UCLA. She has an MBA from the Merage School. She teaches a class here on healthcare entrepreneurship from MD to CEO. Previously, she served as Associate Program Director for the UC Irvine Internal Medicine Residency Program and the Medical Director of the Medicine Ambulatory Clinic. Currently, she also serves as Medical Director of the Premera Blue Cross of Mountain Lake Terrace, Washington, another slacker. She has a wealth of experience, therefore, in all the topics we care about. Please welcome Dr. Batra.
Well, good morning, everyone, and thank you for kicking us off, Dr. Goldstein and the Dean. I'm excited to be hosting the very first panel. How many of us have been following the news more excitedly or not so excitedly every day? All of us, like every day in the morning, I used to go to social media sites. Now I'm like, okay, what happened yesterday? What executive order came out? And so that's exactly what we'll be talking about. What are the healthcare issues at hand with Trump administration? I don't know how many of you read up on the Kaiser Family Foundation news this morning. The House Republicans, in trying to keeping up with the campaign promise of, yes, we shall find the $5 trillion with tax cuts. Where are they going to find those dollars? Where is that easy money to be found? It's in healthcare. And if you're not going to touch Medicare, you're not going to touch Social Security, what are you going to go after? The socioeconomically disadvantaged and poor Medicaid folks. It's interesting, Kaiser Family Foundation also did a poll and found that 50% of Americans either themselves or know of someone who has been in Medicaid. We are here in the state of California. In California, half the kids are in Medicaid. So when we are talking about that $880 billion in cuts for Medicaid, $230 billion for SNAP, that kind of snaps all of us up to see what's going to happen. Many of us, I've been coming to this conference for about 15 or so years, and many of us here are at the heart of it all. We are in this healthcare ecosystem one way or the other, right? Payer, provider, entrepreneur, device maker, all of us get impacted by that as well. But let's not forget the healthcare consumer. It's interesting when I teach a class on healthcare and value in healthcare, and I ask the students, many of them are here, hey, who are the healthcare customers and consumers? And everybody comes up with, oh, it's the payer, it's the regulator, it's the device maker. But we always forget the real consumer, which is us, our kids, our parents. So very, very important issue at hand, and we have two very distinguished guests with us who are going to shed a little bit more light on what's actually going to happen, what is the prediction for the future. So without further ado, let me start off by introducing our panelists today. Avik Roy, who's the president and the Foundation of Research on Equal Opportunity. Avik is working for a think tank which is focused on improving the lives of Americans on the bottom half of the economic ladder using freedom, innovation, and pluralism. He has advised several presidential candidates, including Marco Rubio, Rick Perry, and Mitt Romney. Please welcome me, and please join me in welcoming Avik. He'll be one of our speakers. Second up, we have Sherry Glied. She's the Dean of the Robert Wagner Graduate School of Public Service at NYU. She's been there since 2013. Before that, she was a professor and chair at Columbia University's Mailman School of Public Health. In 2010, Sherry was confirmed by the US Senate as the Assistant Secretary for Planning and Evaluation at the Department of HHS and served in that capacity from July 2010 through 2012. She's also served previously as senior economist for healthcare and labor market and policy under President Bush and Clinton. And we had lots of great discussions last night at dinner, so I'm super excited to kick off this panel. Welcome, Sherry.
All right, so I think I'm going to do some slides first, right?
Yep.
All right, let's go. Let's see if I can figure out how to put my slides in the machine here. There is a USB-C, is that what it's going to do? Let's see if that works. Forgive me while I get set up here. Is this coming on the screen? It looks like it may be. Something's happening.
Good sign.
Okay. That looks promising. I see it on this screen. There we go. All right. Well, good morning, everybody. I just spent the last 24 hours flying here from London, so if I'm a little out of it, you'll know why. People may say I'm out of it in general, but what I'm going to try to do actually is not so much talk about the day-to-day of DOGE and the executive orders. I'm going to try to step back a little bit and try to offer you maybe a more macro or philosophical view of what the healthcare system could look like if we deployed the tools of economic freedom and choice and competition and innovation to deliver it better. There's a doctrine that you hear a lot in healthcare policy circles that the only way to address the issues of affordability and access and quality is to have a system in which the government runs everything. And I'm here to argue to you that there is another way. So let me tell you briefly about the Foundation for Research on Equal Opportunity. So FREOP is a think tank that I co-founded in 2016 in Austin, Texas. We also have offices in Washington, D.C. And our focus is on how to expand economic opportunity to those who least have it using the tools of free enterprise, individual liberty, technological innovation, and pluralism to show that you can actually bring Republicans and Democrats together to achieve progressive social outcomes using what used to be called economically conservative or libertarian policies. And so that's what we focus on, how to use market-based reforms in the private sector to meaningfully improve the lives of Americans whose incomes or wealth are below the U.S. median, and otherwise we're a traditional think tank with a 501c3 structure. So this is a chart that many of you will know well. It's the Congressional Budget Office's chart on the debt to GDP ratio over the last 125 years. You see how it spiked up during World War I, and then again after the Great Depression, and then World War II, and then here we are. And this is what the CBO is projecting for the next 25 years. Oh, my slides are advancing faster than I wanted them to. Let's try that again. I was supposed to shock you, and the element of surprise went away. So let's just try this again, just so I can walk you through what I'm trying to show you here. So this is the historic, what you're going to see in the gray. Again, World War II, it phased down, then the Great Society pops in over here, then the financial crisis, then COVID. And you might call this dark blue part of the slide the long COVID, which is, this is what the Congressional Budget Office's baseline scenario is for the next 25 years, in which the debt to GDP ratio, that is the ratio of the federal debt to our annual economic output, will exceed even what we achieved during World War II. And there is no World War II right now. Maybe there will be one. But what I want to explain to you is that this chart is wildly optimistic. That the CBO, in order to generate these numbers, is projecting that annual economic growth in the U.S. will be 3.6% per year forever. That's kind of like almost 80s, 90s level economic growth forever. And if you just rebuild the CBO's model, which we did at FREOP, and ask it, what if GDP growth per year is only 3% a year instead of 3.6 per year? And I'm sure those of you who are students in the business school understand the power of compound interest. Here's what happens to the debt to GDP ratio if economic growth is 3% a year. So my kids are 8 and 7. This is their entire adult lives we're talking about. This is why I do this work, right? This is, people say this over and over again. Your eyes can glaze over, but this is an existential threat to the world we live in. And I'm going to walk through a little bit of why. And by the way, what's driving the federal debt, the growth in the federal debt? It's healthcare. Every other component of the budget as a share of GDP is actually steady to declining. It's only healthcare spending, federal healthcare spending, that's growing as a share of our economic output. I know it's hard to see in this chart, but you can see that's the one that's sort of like slightly growing up, while national defense and everything else, schools, roads, is declining. Well, there's one other category that's also growing, which is interest on the federal debt. So we're never going to get to 2050 on this chart. How have we survived this far? A question a lot of people ask is, okay, there are all these doomers who go on about the federal debt. Well, why should we care about the federal debt? Things seem to be basically fine. The federal debt keeps growing, but we can still buy our iPhones and go to the grocery store. Yes, there's a little more inflation than we would like, but everything's basically fine, right? Well, no. 2024, in 2024, we made fiscal history, at least modern fiscal history. It was the first year in which federal defense spending, which is this blue line, was outpaced by interest on the federal debt. That's only happened one other time in modern history, and that was in 1934. Here's Medicare, by the way, in case you're wondering how Medicare's doing. That's not good. And you might ask, how do we actually borrow all this money? So the federal debt's now $37 trillion. How do we borrow the money? Now, when you go to the bank to borrow money for a car or a mortgage, you go to the bank and Wells Fargo or Chase decides whether you're creditworthy or not and says, okay, maybe we'll give you, $100,000 for that house or that car or whatever it is, and they'll charge you an interest rate, right? And your credit history might determine what the interest rate is and how much money they lend you. Well, there's no bank with $37 trillion lying around to lend to the United States. So what does the United States do? It breaks the debt into little pieces, like $100,000, and asks you to lend it $100,000. And if enough people lend $100,000 chunks to the U.S., that's how we borrow $37 trillion. And the way the interest rates in true free market are set is if people don't want to lend us the money, if there's not a lot of demand to lend us money, then the U.S. has to offer a higher interest rate to make those bonds more attractive. If people really want to lend money to the U.S., then they can offer a lower interest rate to make the bonds don't have to be as attractive to the buyer because so many people want to borrow or lend money to the U.S. Now, our debt's been going up, so you'd think, all else being equal, people would not want to lend as much money to us. And in fact, that is what's happening. If you look at the share of Treasury securities that have been issued and how much the international market is buying them, that is lending us money, that's actually declining. It's been declining for a long time. It's been declining since the financial crisis. So in a free market, in a true free market for Treasury bonds, that should mean that interest rates would go up, should have been going up for the last 17 years. Now, interest rates have gone up in the last couple of years due to the Fed, but why is it that interest rates were zero for most of this period? There's a simple reason, which is that even though foreign governments and foreign banks aren't lending money to the United States, there's this other entity that is able to lend money to the United States, and that's the United States. So the United States has this really cool government agency called the Federal Reserve, which has the ability to create new US dollars out of thin air and then lend them to the United States, which is kind of like me running up a credit card bill and then taking out a second credit card to pay off the first credit card to make everyone think that everything is okay. But the problem is, as you increase the number of dollars in circulation over time, and there was $5 trillion in circulation by the M2 money stock in 2001. After the financial crisis, we increased it by about 70% to $8.5 trillion. Today, it's about $22 trillion of US dollars in circulation. If you increase the number of dollars in circulation, all else is equal, then each dollar is worth less. It has less purchasing power. The conventional term for that is inflation. Now, the one thing that helps solve for that is economic growth. So if the economy grows at the same pace as the growth in the amount of dollars in circulation, you can sort of manage. You can see in the 80s and 90s and 2000s, we did okay with that. Actually, the economy grew faster than the growth in the number of dollars in circulation. But since the financial crisis, the number of dollars in circulation has gone up a lot faster than the economy has. And that doesn't necessarily reflect itself in things like CPI, the conventional measures of inflation. It manifests itself in all the money that's sloshing around in financial markets, in venture capital, in the stock market, in real estate, in the things that banks and financial firms park their money in if they've been flooded with money by the Federal Reserve. Okay, so back to healthcare for a minute. So I hope I persuaded you that rising federal health spending is bad. What are the big components of health spending? It's, of course, the big three are hospital care, physician care, and drugs, and there's a bunch of other things too. If you look at private insurance premiums, that is premiums for people who are below the age of 65 who aren't on Medicare or on Medicaid, you see a bit of a different map. Prescription drugs is a much bigger component. Outpatient care, the care that happens in physician offices, is a much bigger component. That's why you hear a lot of people complain about prescription drug prices, even though theoretically it's a much smaller percentage of overall national health spending. It's also because they pay for it directly at the pharmacy instead of having their insurers pay for the vast majority of the bill. All right, so I want to speed through, and this is going to be very fast because I have 25 minutes and I've already blabbed for a bit. What can we learn from other countries about how to solve these problems of healthcare? Most of you have heard the almost cliche statement that we spend more than any other country on healthcare and we don't get better outcomes, right? That's something that most people know. I'm going to give you a bit of a deeper dive into what other countries do that we can learn from. So first, what does a great healthcare system look like? I think we would all agree that a great healthcare system would be one in which people have good healthcare outcomes, especially if they are interacting with the healthcare system, right? A lot of times we look at things like life expectancy and say, well, that's a result of the healthcare system. Not really. Actually, life expectancy is most correlated to GDP per capita, economic growth. So that's not entirely within the purview of the healthcare system, but you do want to make sure that people, when people do interact with the healthcare system, they have good outcomes. I believe, and a lot of us believe, that people should have choice. It should not be a one-size-fits-all system. People should have personalized care that addresses their specific medical needs, their specific clinical needs, and their specific economic circumstances. We should have a system in which we're investing in science and technology and innovation. That's been a big driver of improved health outcomes, right, is medical advances in treatments and delivery of care. And we have to have a system that's fiscally sustainable. It doesn't make any sense if we have a system where everyone has health insurance today, but we've bankrupted future generations. Then that's not a system that's actually affordable for everyone. Now, when you look at comparisons of healthcare systems around the world that other institutions have done, there's often a de-emphasis of some of these criteria. You don't hear a lot of these healthcare rankings look at fiscal sustainability or science and technology and innovation. And important countries that we ought to be looking at are excluded simply because they're not members of the OECD. And what a lot of academics in particular like to do is say they just pull the OECD database, reformat the numbers on a spreadsheet and publish a paper and feel very congratulatory about it. But that's not real research, right? Real research is let's look at the whole range of wealthy and interesting countries that are comparators to the U.S., not just the ones who happen to be members of the OECD. And a lot of important countries, as I said, are excluded from the OECD or not members of it. And also, not every country reports healthcare statistics in the same way. And so you've got to really dig into how people are reporting the data to make sure you're doing the best job you can of apples to apples comparisons. So these are some of the countries that are typically included in these cross-country comparisons, the US, Canada, Australia, New Zealand, a handful of Western European countries. What we've done with our project, which is called the World Index of Healthcare Innovation, is we've included the 32 countries with the highest GDP per capita around the world that have a population over 5 million, which catches a lot of other countries into your net, including some countries you're probably not thinking of as comparators to the US, like Taiwan and Singapore and the UAE and Israel, and a bunch of countries in Central and Western Europe. And as I mentioned, what we tried to do in each of these dimensions is be more holistic. So when we look at quality, let's look at economic growth, because economic growth does drive healthcare outcomes. Let's look at, now that we have all the data on the pandemic response, let's look at that. And let's look at an emphasis on patient-centered care. Let's look at choice, not just the choice to choose the coverage and care you get, but do you have access to new treatments in an affordable way? If you have a lot of choice, but everything costs $1 million, and you don't really have choice, right? Choice also includes affordability. Without affordability, you can't have real choice. We should also be recognizing the countries that do the best job of delivering scientific innovation. Where are the patents coming from? Where are the Nobel Prizes coming from? Where is the R&D coming from? Where are new medicines coming from and new medical treatments? Some countries on a per capita basis, not just the US, are doing very well along those metrics. And then fiscal sustainability, not just how it is today, what's your debt to GDP ratio today, or what's your healthcare spending today, but how is it going to look over the next 10 years? What's the trend line? If your healthcare spending is okay today, but the trend line is it's massively going up over the last 10 years, then we should be pretty worried. How is your demographic situation? How many young people do you have in your country? Are there enough people to pay for the system that you've built for the future? So that's what we've tried to look at. And of these 32 countries, we just published the most recent, the 2024 edition. Switzerland was #1 for the 4th straight year. Ireland, Germany, and the Netherlands round out the top 4. And what's interesting about all those countries is that they all have universal health care delivered through private insurers. Now, some of those insurers are nonprofits, and they have various other ways of the way the insurers were founded, but these are not single-payer systems. And yet they've all managed to have universal coverage in an affordable way with access to a broad set of new treatments. If you're curious about how the Anglosphere did in our survey, the US did 7th, Australia 9th, Britain 11th, Canada 18th, and New Zealand 21st. So what can the US learn from our survey? Well, we did 14th on quality. So basically we're kind of in the middle of the pack on quality, which won't surprise many of you. We did extremely well on science and technology. We were so far ahead of everybody else. It's like the biggest gap between number one and everyone else was the US in science and technology. We dominate in that area. But we were actually dead last in fiscal sustainability, dead last. And that is the problem that I want, that ties it to my opening remarks. Why is that? It's because we have the best of worst of both worlds. We subsidize healthcare for almost everybody in America without any regulation of utilization or price. So the single payer systems that manage to execute that kind of system well, yes, they subsidize care for everybody, but they also say no to a lot of new treatments, and especially at regulate price. The more private sector-driven systems like Switzerland, they rely on competition and choice to get the same outcome. So it's a bit like how the ACA is supposed to work, or how Medicare Advantage is supposed to work, where you as an individual can choose among 20 different plans, and they fight with each other on the premiums, and you choose the plan that's relatively less expensive, and that gives all the other plans an incentive to get more market share by also having an affordable product. All right, so that's a lot of complaining. What should we do? So if I were to take what I've just sent you or given you and translate to what could a US-based health reform agenda would look like? It would highlight, as I said, affordability for every generation, not just the generation living today, but the children and the grandchildren of the future. If America's going to go bankrupt by the time my kids turn 21, we have not made healthcare affordable for every generation. It should be personalized. Americans don't want a one-size-fits-all system. We want a personalized system. That's what we're used to in the rest of our life, especially with all the technological tools we have. We've got to apply that to healthcare. It needs to be fair to taxpayers. The fact that all of us pay taxes so that Warren Buffett and Mitt Romney can have government-subsidized healthcare through Medicare makes no sense. Wealthy people in this country should be expected to pay for their own health care. They shouldn't get government subsidies, and yet we do that. The employer tax exclusion gives a bigger tax break to people with six-figure incomes than it does to people making $40,000 a year. These are things we should fix. And we should preserve the innovative element of our system and actually make it better by unlocking more innovation, by attacking the monopoly power in our healthcare system, particularly when it comes to hospital systems and pharmaceuticals, and also specialist physician organizations, which dominate local markets. When I tore my Achilles a few years ago, the anesthesiologist charged more than the orthopedic surgeon to fix my Achilles. Why? Because there's one group of anesthesiologists that owns the entire metropolitan area of Austin, where I live, and they could charge whatever they wanted. Why? So how to get there from here? And again, I'm going to go through this quickly. The first is we need to have a system like Switzerland's, where everybody ideally is choosing their own health insurance, like we do in the ACA, like we do in Medicare Advantage. Those programs are not perfect. I have lots of complaints about them and quibbles about them. But if you have an individual market that functions well, you can start to leverage these market-based principles of choice and competition to keep prices down and keep the system evolving in a way that patients like, and adding in the bells and whistles and services that patients want. Then we've got to reduce the cost of healthcare, right? You can't cover everybody in America if the cost of subsidizing healthcare for everybody is too high. So we've got to reduce the cost of hospital care. We've got to reduce the cost of physician care and prescription drugs. Then we've got to reform the big government programs, particularly Medicare and Medicaid. There are ways to do this. Again, you can means test the program so that we're focusing our scarce resources on the people who are actually vulnerable, who actually need the help, and not funding rich people. And then if you lower the cost of subsidizing that care, you can also lower the cost of those programs as well. So you do those two things, and I would add waste, fraud, and abuse because, again, it's a bit of a cliche to talk about waste, fraud, and abuse, but there is considerable waste, fraud, and abuse in these big programs, and I think that's one of the things that, even though it's in the headlines a lot in a partisan way, we should all be behind higher program integrity in Medicare and Medicaid and other federal programs. Finally, we've got to embrace all the things we can do in innovation. I mean, healthcare has been so slow to adopt a lot of these things, partly because we haven't given healthcare the incentive to adopt a lot of innovation. But there's also just such skepticism. I was having lunch the other day with one of the nation's leading radiologists, and he confessed to me, he said, you know, if AI were the standard of medical practice in radiology, I would have been sued for malpractice every day because I missed so many things that turned out to be cancer later on. Radiology is going to be obsolete as a medical specialty because of AI, unless we prevent it from doing so. And there's literally so many medical errors that are happening today. And again, radiologists, you're all good people. If there are any in the room, I love you. But if we want to make the healthcare system better, we've got to recognize that this technology is transformative. It is going to be better than humans in certain ways. And if we aren't open-minded about that and evidence-based about it and clear-eyed about it, we're going to unnecessarily leave a lot of people behind. You'll be pleased or horrified to know that people in Congress do sometimes hear me out when I pitch these ideas. And there is legislation in Congress that's been introduced called the Fair Care Act that's based on these principles. It would increase the number of people with health insurance. We model about 9 million more people who are uninsured would get coverage, but it actually reduces the deficit because, as I said, it means tests these programs more and reduce the underlying cost of subsidizing health care for the entire country. If you want to learn more about that, you can go to our website, and I appreciate your time. Thank you.
So I'm actually gonna, I think Avik gave a great and really provocative discussion about sort of global macro issues. I'm gonna be much more micro and talk about what's happening right now and facing the administration. So I'm gonna talk about costs. I'm gonna talk for like 2 seconds about technology and the federal role in healthcare policy, partly because I think Avik did a really good job of saying the same things I was gonna say. Hang on, but first I have to be able to figure out how to do this. Sorry, folks. You would think after this many years of teaching, I would be able to do it, but you'd be wrong. Okay, so let me start by talking about coverage. This is a long time series of the insurance coverage of the US population. Nobody really understands what's happening at the very beginning of this graph, and I think probably the data survey changed in the early 1970s, and no one who worked on it is still around to tell us. But what you can see here is that there have been pretty significant changes in insurance coverage over time and in the composition of insurance coverage over time. These are the presidents who were in power during the various episodes of insurance coverage. And one of the things I want to really make very clear here is that politics matters a lot to insurance coverage. Insurance coverage is extremely sensitive to the political situation. The number of uninsured people rose through the Reagan and Bush administrations, flattened through the Clinton administration, fell enormously in the Obama administration, rose somewhat in the first Trump administration, fell again in the Biden administration. This is very much a function of the policies that happened, and of course, of those policies, the most important in terms of the number of uninsured people, if you looked at that graph, is the Affordable Care Act. It's almost the 15th anniversary of the Affordable Care Act. We may make it all the way to the 15th anniversary. I'm not 100% sure. But it's been a pretty challenging time. I like to say there has been, so if you think about that, how many of you were around when the Affordable Care Act passed? Okay, so if you followed the progress of this law over time, you will know that it has been on a precipice many, many times. I don't know why this thing doesn't work very well. There. The phoenix of health reform has risen from the ashes many, many times. I have a slide where I have the phoenix rising and it goes up like 17 times. But I'm just going to focus on the most recent one. So this is the first victory of Donald Trump back in 2016, really very much on a platform of getting rid of the Affordable Care Act. That was very much his health policy at the time. The phoenix of health reform survived that one, but I'm not going to. Why am I having so much trouble with this? I don't know. There's Paul Ryan canceling the vote on the health bill, except I can't. This should be moving fast forward. Remember Trump saying nobody knew that healthcare could be so complicated? Avik will disagree with him on that one. We knew it. McCain coming to the front of the Senate and saying no and putting the thumbs down. You remember all of this? And then finally, after particularly the 2018 midterms, the Republicans saying they're no longer going to repeal Obamacare. That's no longer a big part of their agenda. This seems to be in place. And then we have concepts of a plan. We're still at concepts of a plan. I don't know what the plan is going to be. And I worry about the phoenix of health reform and whether it will actually survive. But I want to come back to what I said before. The politics, the president, Congress have an enormous impact on what happens in terms of just the sheer number of people with health insurance coverage. And if you just look at the very recent past, you can see the enormous gains in coverage that have happened since the Affordable Care Act because of the expansion of federal programs. So you see the big increase through the Medicaid expansions. Those are the blue lines on the bottom, and the big increases in the marketplaces, particularly in the recent past. Just in the Biden administration, we've seen a big increase in the number of people getting health insurance through the individual coverage marketplaces. Just to clarify where that's coming from, the Inflation Reduction Act expanded the subsidies, improved the subsidies for premiums in the individual marketplaces, which led to very big increases in the numbers of people who enrolled in the marketplaces. But those premium subsidies will come to an end at the end of 2025. They cost about $32 billion a year to extend, and they will go away, and presumably most of those people will leave the marketplaces. The second thing that happened is the Biden administration, as well as other things over time, the Biden administration increased the FMAP for states, the Congress and the Biden administration, for a short period of time. That is the Medicaid match that encourages states to participate in the Medicaid expansion. And you can see that more states are participating in the Medicaid expansion than ever before. All but 10 states are now participating. So we've had a big increase in coverage through Medicaid as well. So, just to put this all in context, over the past 15 years, we've seen very large expansions in the number of people who have health insurance in the United States. Okay, does it matter? Well, this is a really interesting thing. I'm an economist by training. Before the Affordable Care Act passed, I asked a couple of my colleagues, Helen Levy and Tom Buckmuller, to tell me, do we actually know whether health insurance improves people's health? And they wrote a paper for a journal called the Annual Review of Public Health, in which they said, look, we know health insurance improves people's access to care, and we have some measures that suggest that they improve some measures of health, but we actually don't know whether health insurance reduces mortality, which seems bizarre, doesn't it? But it turns out that mortality is a very rare event in people under 65. It's hard to find it in data for people under 65. Our surveys are not big. It was not really possible to do it. So one thing that happened in the Affordable Care Act is you will remember that the Supreme Court decided that states could decide whether or not they wanted to participate in the Medicaid expansion. Does everyone remember that bit? Okay, so that was a devastating blow to the dream of universal coverage in the United States and an absolute goldmine for researchers. Okay, because before that happened, everyone said, how are we going to tell whether this law is making a difference or not? There is no control United States. We can't look at what happens to uninsurance in the United States and compare it to anything because we have nothing to compare it to. But since the Medicaid expansion was voluntary, some states participated and others did not, it's possible to look at what happened to people in the states that did participate and didn't participate. And there are now, 1,000 papers that do this. Okay, so my friends went back and looked at the literature. And here's what they said. Studies using, I didn't even touch anything. Studies using different data sources and research designs provide credible evidence that health insurance coverage reduces mortality, particularly true for people in middle age and for children. And they conclude the evidence now unequivocally supports the conclusion that health insurance improves health. So health insurance matters. It's not just another thing. It actually has significant effects on health. I will say we actually do not have evidence like this for most other things in terms of reducing mortality. So there are strong associations between mortality and lots of other things, but actually these are among the most robust studies we've seen. And maybe the one that I like at this moment best, probably the best one, is the randomized experiment. But this is a study by Bruce Meyer and Angela Weiss. Bruce Meyer is an extremely conservative welfare policy economist. He did the following thing. He took a sample of people in the 2010 census, low-income people in the 2010 census, and he was able to match them using administrative data to Medicaid records and to mortality based on the state that they lived in 2010. What you can see here is that the people who were living in states that expanded Medicaid had significantly lower mortality in the subsequent years. So this is just following the same cohort of people over time based on where they lived in 2010, low-income people, and comparing the ones who in 2010 lived in a state that subsequently expanded Medicaid and the ones that did not. So there are many, many studies. We could talk about them afterwards. But what I really like about the Weiss and Meyer study is that they actually look at how effective Medicaid is as an intervention compared to many of the other things we do in the healthcare system. And they conclude that the Medicaid expansion is actually a pretty cost-effective way to improve people's health, to reduce mortality. It's more cost-effective than many other regulatory interventions that we might try. So Medicaid expansion, excellent. Health insurance coverage, really good from a cost-effectiveness standpoint. Not only economists think this, not only health services researchers, but why? There's increasing public consensus that, in fact, the government should be in the business of providing people with health insurance coverage. So everything looks grand. We come out of the Affordable Care Act. The phoenix has risen all these times, and I am really worried, despite the accumulation of evidence and despite the public consensus that the government should be in this business. Why am I worried? Well, because the 2017 Tax Cuts and Jobs Act is about to expire, which means that the government needs to come up with a lot of money, not only to fix the debt problems that Avik correctly pointed out, but just to renew the tax cuts that were put into place back in 2017. And that simple renewal of the tax cuts is going to cost about over $4 billion. $4 trillion over the next 10 years. So where is Congress going to find $4 trillion? Really, there's only one good place to find it. You have to follow the Willie Horton rule. Do you know who Willie Horton was? Willie Horton was a very famous bank robber. Somebody asked him, why do you rob banks? And he said, because that's where the money is, right? So why are you going to go after healthcare? Not because healthcare is unnecessary, not because we don't think Medicaid expansion saves people's lives, but because that's where the money is. And if we look at where healthcare is in the budget, okay, healthcare in the budget really shows up in two places. One is in the Department of Health and Human Services, and the other is in the Treasury Department. Avik talked about the tax treatment of employer-sponsored health insurance. Both of those places have the money in them. And what is that money? There's about $1.7 trillion in mandatory spending each year coming out of the Department of Health and Human Services, about $140 billion in discretionary spending. All that DOGE stuff is going after that, mostly that discretionary spending. And then in the Treasury Department, there's about $190 billion in the tax expenditure associated with employer-sponsored health insurance. So if you're looking for $4.5 trillion over the next decade, you're going to be looking at these programs. The president has been unequivocal that Social Security and Medicare are off the table. He's also said Medicaid is off the table, but my guess is that they're probably not going to keep to that. So when people talk about what is likely to happen, how are we likely to pay for the extension of the tax cuts, I'm sorry. This is a list that the New York Times found. I'm not sure, I'm not an investigative journalist, of where you might find some of that money. I really want to focus on a couple of places. These are all Medicaid savers. The $900 billion one over 10 years is what are called Medicaid per capita caps. That is setting Medicaid payments to the states simply on a per capita basis, maybe a per low-income person basis. The second one is reducing the federal share of state payment of the cost of the Medicaid program for the expansion population, the people who gained coverage because of the Affordable Care Act. The third one, which I hear a lot of noise about, is work requirements in the Medicaid program. So I think these are the three places that we think are most likely to attract congressional attention as a way of paying for the Tax Cuts and Jobs Act. So what will these do? I think many of you may be familiar with this meme, right? So what people are going to say is we're going to change the Medicaid program, we're going to do per capita caps, we're going to change the FMAP, we're going to install work requirements, and that's all going to improve the incentives that are in the Medicaid program. Because right now, the Medicaid program has the federal match on the Medicaid program says the more a state spends, the more the federal government sends over, right? All of you who've taken economics know, very perverse incentive, right? The more I spend, the more money I get from the state. Work requirements, right? That would seem like a disincentive to working if you can get Medicaid when you're not working. So people will point to the idea that our current system has perverse incentives in it. And what I'm going to tell you is perverse incentives or no perverse incentives, the savings that you get from reducing these programs don't come from the change in incentives, they come from cutting enrollment. They come either from cutting enrollment directly, or they come by shifting costs to the states who turn around and cut enrollment. So the Medicaid program runs very lean, pays very low amounts. Actually, one of the amazing things, well, I'll talk about it in a minute. Turns out the Medicaid expansion in a projection sense cost nothing to the federal government. There's lots of fraud, there's lots of waste, there's lots of abuse. Overall, the program runs very efficiently and is very low cost. So cutting the program is really just about throwing people off coverage, whatever excuses people may make for it. I do want to say there are other places to go in the budget if you wanted to fund healthcare. And I think I appreciate that Avik raised the same point. There's $190 billion in that tax expenditure for employer-sponsored health insurance that is really not getting a whole lot of coverage. We're not getting a lot of good out of that piece. Okay, sorry. This is the cost per newly insured person. So the cost per person that you add coverage for, if you do it through the tax exclusion, it's about $100,000 per additional insured person. If you do it through Medicaid or the new expanded subsidies in the marketplaces, it's much, much, much less than that. So if we were trying to do healthcare reform to save money, if we were trying to realign incentives in ways that were less perverse, we'd probably go after the employer-sponsored health insurance subsidy. We are not going to go, here's my projection, right? It's very hard to make forecasts, especially about the future. I'm going to tell you, Congress is not going to go after this $190 billion. This is going to stay there, and if they go after anything, it will be the Medicaid program, which is a much, much more efficient program. Okay. Beyond what Congress is going to do, the other thing I want to point out is that even without congressional action, the role of the president, the executive branch has a lot of impact on what happens to coverage, even through its regulatory actions. And you can see that there were increases in uninsurance in several administrations, even in the absence of legislation that would have had a major effect on coverage. So we can expect to see, even if Congress doesn't dismantle big parts of the Medicaid program, we can expect to see rises in uninsurance over time anyway through various regulatory actions that we can talk about later. Okay, coverage. Let me talk for a minute about cost. The first thing I want to say about cost is, unlike coverage, presidents and politics have relatively small effects on the cost of healthcare, even on the federal cost of healthcare. That's kind of a surprising thing. One would think that federal policy is really important here, but it's actually hard to trace out the effects of federal policy on healthcare spending, with the small exception of Part D. You can see that in both Republican and Democratic administrations, healthcare spending has grown, and that it doesn't always happen in a way that you would think was associated with the politics of the person. So the two periods where we've had actually the slowest growth in healthcare spending over this period have been the administrations of Bill Clinton and Barack Obama. In the Obama administration, even though the Affordable Care Act happened, healthcare spending at the end of 2019 was lower than the CMS actuaries had forecast in 2009. So let me just explain what that is, because it's kind of an amazing thing. In 2009, before the Affordable Care Act was even dreamt up, the forecasters at CMS, at the Centers for Medicare Services, they did a projection of healthcare spending. Avik showed you a bunch of those projections, just about all the things that are likely to happen in the future. Really hard to make projections about the future. So they projected what healthcare spending would look like in 2019. Okay, so it's 2009, they're projecting to 2019. After they make their projection, the Affordable Care Act happens, right? And all these people gain health insurance coverage. And yet, despite the big increase in health insurance coverage, actual realized healthcare spending in 2019 was below the 2009 projection. So healthcare spending grew very, very slowly during the Obama administration. Okay, does this mean everything is okay? Well, no. There's a lot of work on international healthcare comparisons. I'm not gonna get into all the details of it. I'm gonna do a really simple one here. I have a bunch of countries. I was lazy. But I'm actually particularly interested in places like Australia. It actually has a really interesting healthcare system. Japan is in here. What I think is really interesting is this is data from 1976. So whatever you may think about these countries, one of the things that's interesting about this diagram from my perspective is that in 1976, the US was not an outlier in its healthcare spending. We looked like all these other countries. We also look like all these other countries in terms of male life expectancy at age 40. That's a measure I really like because many of the perversities like violence, drugs, things like that, that we think of as particularly American pathologies, mostly hit people younger than that. So you think that by age 40, you're seeing much more of the impact of healthcare. And in fact, if you remember this, the slide I just showed you about the mortality impacts of Medicaid, a lot of those mortality impacts are on older people. So we generally see that healthcare spending, where it matters, is among people who are 40 and older. So here we've got male life expectancy at age 40. I'm doing males also because women look even much, much worse than men in the comparison I'm about to show you. So I'm giving you the best possible case. All right, everybody sees this in 1976? You know what these countries are, right? Okay. That's 2016. Now, you could tell me anything you like about choice and innovation and everything else. This is a pretty sad picture. And it suggests to me that there's a lot the United States ought to be able to do to save money in the healthcare system. We ought to be able to get outcomes that are at least closer to those of, you know, good, clean living countries like Canada and Australia. Not, right? Even without, you know, and not spend quite as much money as we do. We look at Switzerland, which has always been the most expensive of these countries, but even Switzerland is spending far, far less than we do. I've actually updated these numbers to post-pandemic, but they look so awful. So they're from 2022, and our life expectancy has dropped even further, and I think some of that is pandemic related. So I prefer to just stick with the 2016 number. I think there are two things that are interesting here. One is, there's lots we can do, right? That there clearly is, we are not on the frontier of efficiency in healthcare, clearly, right? The second thing is, in some ways, this is what gives me some hope when I look at Avik's debt numbers. I think of this as like a pot of gold. Someday, we will be able to retrieve that pot of gold and pay off our debt. Maybe keeping it in the healthcare system for now is a better place to keep it than to give it back to people in tax cuts when we will never get it back. I don't know. This is my really cynical view of the healthcare system. Okay, what could we do? Well, the thing about this is, if you look at where this is coming from, it is not because of high prices in our public health programs. Our public health programs actually look a lot like the performance of other countries. Right? We pay in Medicare rates that are similar to what the rates that are paid in most of these other countries, all of which, by the way, regulate prices. They're all price regulating countries. So they all regulate hospital and physician prices. So, and our Medicare payment rates are not crazy. It's our private payment rates where most of the action is. So it's really on the private side and not on the Medicare side that we have a cost problem. So what will we do to control costs? I wish I had an answer to this question. We've tried a lot of things. We've tried deductibles and having people have more skin in the game. This used to be a big story, right? We're going to get people to pay more costs out of pocket. They'll be more careful about their healthcare spending. That'll be great. We've just finished some research on HSAs and high deductible plans. The short answer is it doesn't make any difference. It does not, in the long run, reduce healthcare spending. We've talked about utilization management. That's clearly not going to increase in the next little while. There's incredible pushback against the idea of managing care. Competition enforcement. Well, competition enforcement sounds like a grand idea, and I'm all for it, But there are many parts of the healthcare system where, frankly, competition enforcement is not going to work. And one of them, perhaps the most important, is hospitals. We've talked a lot over the past 2 decades about the importance of increasing competition among hospitals, but over the same period, the scale economies in hospitals have grown. It is much, much less efficient to run a small hospital compared to a big hospital, given the capital demands of hospitals. And the second thing that's happened is that length of stay has dropped, and we've moved more and more care out of the hospital. What this means is that there are fewer and fewer communities in the United States that can actually sustain a competitive hospital market. Very few communities can actually sustain 3 hospitals of adequate size, right, that are providing care to their community so that you can actually get robust competition. So I think while all of these ideas are in principle good, they're probably not going to work. And we may need to think about more robust ways, including price regulation, to think about regulating costs, especially in uncompetitive markets. I'm going to spend 1 minute talking about looking forward. I think the first thing that all economists learn about healthcare, actually everybody should learn about healthcare, is that the secret of healthcare is innovation. Change and innovation and learning things is the thing that drives the healthcare system forward. So I do worry that we will underfund the NIH, underfund the FDA, slow the pace of innovation in healthcare, and that may actually reduce costs or keep the rate of growth of costs down, but it will come at an extreme expense in terms of what's going to happen to our own health. GLP-1s, which I think is just a fascinating, really interesting new innovation in healthcare, and could have monumental effects on both healthcare costs, hospital utilization, Medicare forecasts. If everyone is healthier, maybe healthcare spending is not going to grow at the pace that we thought it would. We've actually seen this happen once before. Part of the reason that spending growth slowed so much in the 2009 to 19 period is because cardiovascular disease is better dealt with and smoking has declined. So there is hope that actually changes in the technologies of health might slow the rate of growth of spending, but they're also going to have enormous effects throughout the system. And making sure that people have access to these treatments is going to be very important. I think right now we're in a kind of panic mode. These things are very expensive. They're blowing holes in everybody's insurance plans. I think that's a bad way to look at them. What we really should be thinking about is financing care for people that is likely to improve their health and well-being and perhaps even costs in the future. We have to worry about, I think, especially in a market that is very much more individual, and I think there's lots of arguments that are good in favor of moving towards a more individual market for healthcare. One of the big challenges there is that as you have extremely costly therapies, unless you are pretty strong in your regulation of what the individual market covers, unless you actually specify that everyone is entitled, everyone who needs these things is entitled to get them, you can actually have a pretty bad race to the bottom in the individual health insurance market. You're going to have a very hard time getting these therapies covered. So we do need to think about making sure that we have adequate controls in place to make sure that those therapies are available to people. And finally, AI. I completely agree with Avik. There's real potential for savings here, and there's also real potential for lobbying and politics to get in the way of the savings that we might be able to identify and come to. So let me stop there. And I hope that's it. Thank you.
Thank God it moved. Well, thanks so much, Sherry and Avik. That was really thought-provoking. We have a lot of time for questions, so people should start getting ready with questions, and we'll have microphones going around. I'll start off with a question. So healthcare is personal. Healthcare is complicated, as President Trump said. We spoke about $5 trillion in tax cut, and where are those big dollars? They are in healthcare. Unfortunately, there's no other couch to shake. Medicare is off, Social Security is off. Medicaid, 41 states have expanded it. There are states like Alabama that have 66% in terms of federal match. There are enhanced subsidies. If they go away, I think I read somewhere it impacts 75% of the people. There are folks who are in long-term care who are impacted. Their kids who are impacted. They're socioeconomically disadvantaged folks who are impacted. While President Trump, in the first go-around tried the healthcare reform, didn't work, and repealed the ACA, it's not too far out. Midterms will be upon us, and everybody pays attention to it, both Republicans as well as the Democrats. So with that, all that background, and you just forecasted that perhaps Medicaid is not going to happen. So the next step is the employer insurance and the taxes. What do you both feel is going to happen? Are we really going to go there? Are we going to go on Medicaid? So what's going to happen? Where are we going to find that money?
Well, I would just say that, Sherry described the Medicaid program as this lean and mean, incredibly efficient healthcare system, the SpaceX of healthcare, if you were. I'm not convinced that that's the case. In fact, quite the opposite. The Biden administration's Government Accountability Office estimates that somewhere between 10 and 30% of all Medicaid spending is improper payments. And let me just give an example from the ACA, and it does translate to Medicaid to explain a little bit of why. So when you sign up for a plan on the Affordable Care Act's marketplaces, in order to calculate what amount of your premium gets subsidized, you have to estimate what your next month's monthly income will be. And based on that, you get a certain subsidy. Now, it doesn't take a rocket scientist to predict that people have a powerful incentive to be, let's say, pessimistic about their future income in order to capture better subsidies in the ACA. And the way this works is you put it in, it's kind of an honor system setup, and then in theory, the IRS can look back on whether you told the truth or not about your income and then claw it back. In reality, in order to juice enrollment numbers in the ACA, Democratic administrations in particular have not clawed back the money. This whole system has led to pretty significant increases in improper enrollment from people who are not eligible for certain amounts of subsidies. Same thing happens in Medicaid, where, as you can imagine, because a lot of people in Medicaid are very low income, they don't even file tax returns. There are simple ways to fix this, such as connecting a bank account to your eligibility consideration so that you can determine these things in real time. The DOGE crew is working on this, right? So something very simple like that can help address the problem of people who are ineligible for the program. And there are certain numbers that are like crazy in terms of the number of people enrolled in certain states is actually greater than the number of people who are in those income brackets, particularly because of the enhanced ACA subsidies. So Medicaid is actually not this lean, mean, efficient SpaceX of healthcare. It pays providers the least. So in that way, you could say it's more, quote unquote, efficient in the sense it's spending less on care, reimbursing providers less. But in terms of its actual efficiency in delivering the care to the people who are actually eligible for it, and having a benefit design which rewards the right kind of care that will lead to the best health outcomes, their Medicaid is broken. And I thought it was really interesting when Sherry talked about here's the plot in 1976 and here's the plot in 2016. What happened between 1976 and 2016 in America? Was there a flourishing of free market healthcare between 1976 and 2016, or was there a massive growth in Medicare, Medicaid, and the Affordable Care Act? Right. So again, this is not to say that governments don't have a role in making healthcare more efficient. It's just the particular way we've done it in the U.S. is incredibly inefficient. Amy Finkelstein at MIT has done the work to suggest that most of the health and care inflation we've had over the last 50 years has been driven by Medicare. So there are ways to fix this that don't involve cutting benefits for poor people. You can actually improve through digital identity and better verification tools, making sure that the people who are eligible for the programs are the ones that are actually enrolled in them. You can make it easy for poor people to enroll, actually, by eliminating the waste, fraud, and abuse. And there are other things that we can do in terms of improper payments to make sure, because there's a lot of just gaming the system that the providers do too. So if you fix those things, you can actually save a lot of money without actually harming low-income people. So this idea that the only way to reduce spending is to harm poor people is, I think, a very simplistic way to think about reform.
I can see a very healthy debate happening there.
So I didn't put up all the other years, but I will note that most of the difference between the U.S. and the other countries had emerged before 2006. I actually put up normally I give this talk and I put up all the years, so it doesn't matter.
And was Medicare passed?
No. I mean, it could have been Medicare. Medicare had been in place for 10 years already, right? So it could have been Medicare, although all these other countries have universal health insurance. So it's hard to see what it is about Medicare that is really different from Canadian Medicare, which looked exactly the same at the time.
Oh, quite a bit.
No, no. In
Medicare doesn't
1976
regulate prices or utilization
No,
the
no.
way that
In
Canada does.
1966, Canada didn't either. So whatever. Eventually, they did. So it doesn't matter. I'm actually not saying I would not say that the U.S. is the best healthcare system in the world by any means. I think there's lots of savings we could do, and I think we should look at the other countries that Avik points to. Taiwan, of course, has a really strong. I mean, they're all different. Every country has a different healthcare system. Actually, let me just stop there for a second. One of the things I find really interesting about that graphic is that all those countries have radically different healthcare systems from one another. So I have up there Japan and France and the Netherlands and Switzerland and Germany and Canada. And what is astonishing to me in that picture is that they all look very, very similar to one another and very, very different from the United States. So it's not, so you know, you want to think about theories where if you throw out the US, your theory still holds. And it's hard to come up with theories like that. Does that make sense, right? So you'd like to take out the US data point and say, you need this, because if you look at all these other countries, you see that this thing drives the differences among them. That turns out not to work for most of the explanations we can come up with. Let me go back to Medicaid, though. Absolutely. First of all, improper payments are not at all the same thing as fraud, waste, and abuse. Improper payments, which you all experience in your health insurance, are when somebody submits a claim and it gets denied because something was wrong on the form and it gets redone, re-adjudicated. So they're not good, but you should not assume that 10 to 30% improper payments has anything to do with how much fraud, waste, or abuse there is in the program. These are separate, just separate issues. You shouldn't have improper payments, that would be good. Lots of people on Medicaid do not have bank accounts. So connecting their Medicaid to their bank account is not going to work because they are unbanked. That's a big problem. But the bigger problem is this. There is absolutely fraud in the Medicaid program, absolutely fraud in the private insurance program, absolutely fraud in self-employed taxation, absolutely fraud in all sorts of things, right? One has to make a decision about how much you want to put into anti-fraud efforts and how much you're going to gain from it, right? So if you go after people, it's going to cost you money to go after them. Is it worth it to do it? If we could come up with a better way to automate all of this, lovely. I would love to see that. Everyone would love to see that. States have a big incentive to do it. They could have done it. Some of them could have done it. We haven't seen it happen. In the meantime, what we have seen happen is every time there is an effort to do one of these things, the number of insured people falls. If it were all fraud, waste, and abuse, the number of insured people should not fall when you try to tighten these things up. The number of insured people should stay the same, and we ought to see, shuffling around of it, but that's not what we see. What we see is the number of people with coverage falls. Now, I will say this. If you move people from Medicaid to the privately insured Obamacare marketplaces, spending on those people increases. So, yes, we'd save the money on lower provider costs. Somehow the per capita cost of people on Medicaid is quite low, even though some of them might be in there fraudulently, even though we should go after all of that stuff. But that is, remember those, like the numbers that I had up there? You're not going to get a lot of big numbers throwing off a few people because they lied on their Medicaid expansion form. We also know from the EITC, the Earned Income Tax Credit, that actually people do not understate their income systematically. They are actually petrified of having to pay back large amounts of money at the end of the year. So while there are instances of people who are under predicting their income for the tax credits, there are also lots of people who are over predicting their income because they are worried about getting hit on the other end. So, yes, there is, I think it is really easy to find individual people in individual cases who have messed up and who have lied on their taxes or whatever. You can always find such people. The question is whether it is efficient to whether there are efficient ways to systematically do better in matching people to programs. And if there are any such ways, we haven't seen any states effectively implement them yet. So let me leave it there. We have the states are the laboratories of democracy. If it's really so easy to do better job on Medicaid eligibility, we ought to be seeing some places that are doing it, and we haven't yet seen them. So I'll leave it at that.
Let me just quickly respond on a couple of those points. So I'm glad we're having this conversation because it shows that there is actually a robust conversation to have about the efficient delivery of these services. First of all, Sherry argued that states have an incentive to make their Medicaid programs more efficient. That's not completely true. Because the way the Medicaid program is financed is, particularly the expansion population, is it's almost entirely financed by the federal government. So if the states contract enrollment in that program, in which the vast majority, 90 to 100%, depending on how you count it, is coming from the federal government, that's basically free, quote unquote, free federal money from the Washington that's going to their states. States don't have an incentive, in their view, to cut that money back. So they actually have an incentive for inefficient enrollment and spending in Medicaid, and that's
So
part of
would
the
you
problem.
say that Medicaid enrollment has become substantially more inefficient in, say, New York State since Medicaid expansion has?
I would say in general, that's one of the big problems, this kind of principal agent problem. Medicaid has been true from
I
the
showed
very,
you,
the
that
very
was
beginning.
that was my,
Well, just
that
hold
was
on
my
a second.
distraction meme.
Yeah, so there's a very simple way to fix this, which is to actually migrate able-bodied adults who are low income into the ACA exchanges, where the subsidies are 100% federally funded, and then you eliminate this gaming through provider taxes and other things that states do to basically drive this inefficiency. And every governor will tell you privately that they do this, by the way. And then the other thing is, like Sherry argued, that the ACA programs are more expensive. ACA coverage is more expensive than Medicaid. Now, that was theorized at the start of the Affordable Care Act. The Congressional Budget Office predicted that it would cost $9,000 per patient per year to cover someone under the ACA exchanges, and $6,000 per patient per year to cover someone under Medicaid, which is literally why the ACA coverage expansion was done with the poorest people on Medicaid and the middle-class people on the ACA, because it was cheaper, they thought, to do so. But in reality, that isn't showing to be the case. So the latest CBO numbers indicate that actually, on a per capita basis, the Medicaid expansion population is more expensive per capita to fund than people are in the exchanges. So it's not as clear, because a lot of what's happened on the ACA is that the plans that are succeeding on the ACA exchanges in terms of delivering products that people want to buy are the Medicaid managed care companies, Molina, Centene, and companies like that, who are basically offering Medicaid prices on the exchanges. So it's not at all clear that Medicaid is more quote-unquote efficient in terms of paying providers less, and that the ACA might be more efficient in terms of the structure of its financing. And also, it reduces a lot of churn. So one of the big problems in terms of quality of care and coverage that happens right now is, if your income goes above an arbitrary percentage of the federal poverty level one month, and it goes below it the next month, you have to completely switch from being on Medicaid one month and being on an ACA plan the next month, and completely refigure out, is my primary care doctor in that provider network or not? How is that in the interest of anybody who has a lot of other things to juggle when you're poor to begin with? So we should eliminate that friction and actually have all those people on the ACA exchanges. We also have to improve the way the ACA exchanges work, because there's a lot of needless regulatory design stuff in the ACA that actually makes the ACA plans much more expensive than they ought to be. The premiums doubled in the individual market the year that the ACA went into effect, and they didn't have to protect people with pre-existing conditions. So all this to say, look, I'm glad we're having this conversation, because what it shows is there are lots of things we can do to make healthcare more efficient. We kind of talk out of both sides of our mouth. On the one hand, we say, oh, isn't it so terrible that the U.S. has the most expensive healthcare system in the world? We spend more per capita and have the worst outcomes. And then we say, there's nothing we can do to reduce healthcare spending, because if we do, poor people will die. Well, which is it? Which is it? That's what we have to decide.
So I'm sorry, Avik, can you just explain to me why moving the Medicaid population to 100% fully federally funded marketplace is going to reduce federal spending?
We'll just do one
because
comment.
you eliminate the waste, fraud, and abuse that comes from the fact that states have an incentive.
But they're the same people, right? So we're winding up, we're just taking mostly the same people. We're moving them from a 90, there are a few,
it's very different.
There are some people, let's just say 10% of the people are waste, fraud, and abuse people, right? So they wouldn't get on something where their subsidies will be a little bit smaller, because they're really at 175% of poverty, and they're telling us that they were at 100. But is that really going to save money on the federal budget? I don't have any objection to it. I don't care. I mean,
I think you're describing waste, fraud, and abuse in a very narrow way, which is just whether people are eligible for the program or not. There is an element of that, because as your income goes up, the amount that the ACA subsidizes your coverage and your copays and deductibles does start to gradually go down. But the bigger issue is the accounting gimmicks that states use to offload their share of the Medicaid match onto the federal government, which is a massive form of waste, fraud, and abuse.
Fine. I totally agree with you. Totally. Okay,
All right.
fine.
Good.
Let's
move on then.
but I just don't, I'm just having trouble with the math.
Oh.
Okay, the math is there is a federal Medicaid program that's paying 50 to 90% of expenses depending on the state. And if we move all those people into a program where the federal government pays 100% of their expenses, you think the federal spending is going to drop?
Actually, if you model it out, because of all the provider taxes and other accounting gimmicks that the states put in, the spending doesn't turn out to be that different. That's how much fat there is in the way states finance their Medicaid programs.
All right, so maybe there isn't as much additional cost to the federal budget as I would think, but it's not going to reduce the federal budget.
I think we'll do one more, but I love this healthy debate, and
just
I also know all our folks in the audience.
I'm not describing that as the reason to that's not, moving people onto the AC exchange is not the thing that's going to save the government money. Like, that's not the solution to the deficit.
Fine,
It is, but it is a tool for more efficiency that can lead to other efficiencies down the road that you can build on.
okay. So
There's
I
lots
have
of
no-
other, if you want to read my whole white paper, we can
will.
talk about it another day.
I have no problem with that. I think I agree with you about churn. New York State actually has a basic health plan, so we don't really have nearly as much churn. But, I agree with you on the churn issue. I probably don't agree with you on the extra ACA regulatory stuff, but that's okay.
That's why we're both here and not just you.
Exactly. That's
always
right.
good.
We do agree on, like, we should change the employer-sponsored health insurance tax treatment, right? Which no one else agrees about, so.
Well, this is a great debate, and the key message here is there's always room to improve.
There's
there are
always
different
room to
ways
improve.
of improving. I still did not hear the answer on the employer insurance and taxes, but that's fine. We'll go to the audience because they've been waiting patiently.
The one question or thing that I see that you're not discussing is to reduce prices by giving better care. And so some of the things I'm thinking is healthcare's been captured by big pharma. We know this. Everything is a pharmaceutical result. Anything that's covered by insurance is mostly surgery, pharma, very little in the therapeutics. There's some. And so there have been, and RFK's talked about this, I've worked a lot with this, some things with frequency medicine therapies that have shown extremely good results. And they are not covered by insurance. They are not in big healthcare institutions. It's the private practices that are having to use this to be able to help actually heal patients. So can we talk about how we actually get better outcomes by opening the aperture of what kind of therapies are used and approved and studied as opposed to just the pharmaceuticals?
Well, we should talk about the pharmaceuticals for a bit because it is something that a lot of people care about. And the thing to understand about pharmaceuticals, I spent 12 years as a biotech and pharma investor before I started becoming a health policy guy. And so I have, in a certain way, very cynical view about the pharmaceutical industry because I've seen up close some of the strategies they use. The CEOs tell you straight up when you're an investor in their companies. But also, obviously, the innovation and the advancements in treatment and care that come out of pharmaceuticals. And the way you need to really think about it is 90% of the prescriptions in the US are for off-patent generic drugs that cost literally less than this bottle of water. That part of the healthcare system is working pretty well. If you have a small molecule drug that has had its on-patent life and then it's gone off-patent, like atorvastatin today, a cholesterol-lowering drug that used to be a $20 billion drug, that drug is basically free now and has done a massive job in improving health outcomes in the United States. And that's true with high blood pressure drugs, it's true with oral antidiabetics, it's true with antidepressants, it's true with antipsychotics. There are huge categories of medicines that are basically free now that used to be expensive. The areas where prescription drugs in the US are expensive is that small, narrow group of drugs that are still branded drugs, on-patent drugs, and that's some drugs that are relatively new. But it also is largely nowadays biologic drugs, drugs that are engineered from living cells, that are like monoclonal antibodies used in cancer treatments and things like that. And the reason for that is because Congress, in its infinite wisdom, decided to design the generic market for biologic drugs completely differently than it did for small molecule drugs. So the small molecule system was built in 1984. There's a law called Hatch-Waxman that basically regulates that. Biologics are driven by Title VII of the Affordable Care Act, the Biologics Price and Competition Innovation Act of 2009, and the pharmaceutical industry, because they were recruited to support the ACA, inserted all sorts of loopholes and exceptions and time bombs into that legislation to make it a lot harder for so-called biosimilar companies. Notice the word biosimilar. It's also like a propaganda win for the biotech industry, which is, oh, they're not generics, they're not identical, they're just similar, right? To make you mistrust them. But that market is has emerged very differently. And that's a big part of the problem. Your question was like, okay, let's just move away from drugs altogether and talk about things that aren't prescription drugs. And I think insurers can do a better job of that. It's up to insurers to start thinking about some of these things that can save money. And I think the thing that I try to tell insurers to do is manage more of your pharma spend directly as opposed to outsourcing it to pharmacy benefit managers, because I think that's what's led to a lot of this spending inflation on the pharmacy side.
I guess I would just, I actually completely agree with Avik on everything he's just said. And I would also say that one of the things, maybe it's good, maybe it's not good about the US healthcare system, is that insurers, especially in the private market, especially in the employer market, even in the individual market, can choose what they want to cover. And if they want to cover different kinds of therapies, and they can do that. They have covered at various times. Acupuncture, chiropractic became common because insurers began to do it. In principle, I would say the argument in favor of having a more free market health insurance system, and I'm actually a fairly free market person, is that kind of innovation in coverage can occur, and we should see it. But it's up to, it's basically what insurers do is what people want. If lots of people want coverage of things, insurers will usually come up with some way to cover it, because they're in business, and we'll see that happen. I don't know, my view would be that we oughtn't to provide tax subsidies for these things, but leaving that aside, they can cover it.
Absolutely. Working for one, I see that all the time, things that may not have been tried in Medicare. If there's demand, acupuncture is a good one. Medicare doesn't cover it. Of course, the health insurers cover it. Oh, perfect. We have a question here. Where are we going? Back.
You both mentioned fraud, waste, and abuse being a big challenge. When one looks at the public and private market, who is responsible for the majority of dollars spent in fraud, waste, and abuse? Providers or members?
Providers. No question.
Providers or what? What was the second choice?
Members.
Or members,
Oh, it's
beneficiaries?
providers. It's definitely providers.
Oh, and by the way, that brings me to a point I wanted to mention earlier from Sherry's talk, which is that she argued that competition policy, while she supports it in theory, she doesn't think it's going to really have much of an effect. And I will strongly disagree with that. There is a lot to do. There's so many things that are going on behind the scenes that most people don't know about. The Wall Street Journal actually has done some really good reporting on it recently in terms of the anti-competitive provisions in contracts, where a big regional health system will say, you, health insurer, are not allowed to steer your patients to a competing hospital, because if you do, we will freeze all of your patients out of our network. That's literally illegal.
Right.
But they put it in the contract, and the contract is confidential. And so the insurer cannot say, hey, everybody, this is illegal, because if they do, they're worried they're going to get sued. And so Congress has considered, but not enacted, legislation, and states are considering this too. States are considering legislation along these fronts to try to do something. Here in California, when Javier Becerra was the Attorney General, he actually launched a massive lawsuit against Southern Health, which dominates Northern California, on exactly some of these factors.
So I actually want to be very careful here. I don't think we should stop on competition policy. We should be trying to do everything we possibly can. All I'm saying is there's actually a limit to how far we're going to be able to go, and we have to recognize that.
Perfect. One last question.
Hi. I want to ask about the growth in Medicaid spending for the population that's over 65. And where do you see that, since we do have an aging population, and we know that many of them are Medicaid coverage for their long-term care?
Yeah, it's a great question, a really important area, and I think an area more people are paying attention to because the population is growing, of course, because just the baby boomers are retiring, and so there are more people in general in Medicare and more people who are dually eligible for both Medicaid and Medicare. And this is where I think there is a lot of non-ideological, nonpartisan discussion about it, because I think we all agree that the fragmentation of health insurance between Medicaid and Medicare for that population creates massive inefficiencies. The bright spot in this area from my vantage point and our vantage point at FreeOp is that there are Medicare Advantage plans and versions of Medicare Advantage plans that are trying to integrate the Medicaid and Medicare benefits in ways that seem to be achieving some of those better quality care because it's more integrated and better managed and also less costly.
Yeah, I would agree on that as well, that moving to plans for duals is a good idea. I do think that we have to think very hard about how we're going to deal with long-term services and supports for the aging population, especially as the population under 65 does not grow very much, especially if we're going to do something on immigration. We are going to face some real challenges there, and we do not have a financing scheme in place, and we had better think about that.
Awesome, and I know California is leading the way in terms of medical transformation with focus on duals, going through high D-SNP and 5D-SNP, and so yeah, that's all great. Well, this was an amazing panel, and we got to hear two amazing sides of the
We're all awake
story.
now.
I would like to thank everyone.